Look at the baseline characteristics of patients with or without diabetes in both Asia and non-Asian countries. What we found that the history of hypertension, BMI, hypercholesterolemia, heart failure, vascular disease, CKD was higher in diabetic population compared to non-diabetic population. But when we look into the non-Asian population with diabetes versus Asian population with diabetes, the non-Asian population with diabetes, they had more risk factors. If you look at the Chadwell score, patients with diabetes, they have more Chadwell score compared to that of the non-diabetic population. Looking at the treatment approach, which was almost similar in both the diabetes and non-diabetic population, both in Asia and also in non-Asia. But we go into the further details. We found the patient with non-Asian patient with diabetes, they were more on anticoagulants compared to Asian population with diabetes. Looking at one-year outcome of the patients with and without diabetes, the stroke and systemic embolization, the major bleeding, all-cause mortality, cardiovascular mortality, non-cardiovascular mortality, new onset of acute coronary syndrome, congestive heart failure, was more in diabetic population compared to non-diabetic population as expected. But when we compare the non-Asian population with diabetes versus Asian population with diabetes, we found all these risk factors were prevalent more in non-Asian population compared to that of Asian population. Coming to the other risk factor of chronic kidney disease, in Asian countries, the Thailand had the highest, 38%, followed by Singapore, and the lowest we saw was in Korea, it's 2.1%. Looking at the baseline characteristics of this patient with or without CKD, just like diabetes, we observed almost similar findings, that patients, those who are on CKD, compared to non-CKD patients, they had more risk factors like hypertension, hypercholesterolemia, heart failure, vascular disease, and the Chadwell score was also higher in CKD patient compared to non-CKD patient. Similar to diabetes, what we observed was that non-Asian patient with CKD compared to CKD patient in Asia were again having higher risks like hypertension, heart failure, vascular disease. Coming to the treatment modalities, in patients with CKD and without CKD, surprisingly, both in Asia and non-Asia, the CKD patients and non-CKD patients both were equally anticoagulated. But again, similar to diabetes, when we look into the non-Asian population versus the Asian populations on oral anticoagulants, both vitamin K antagonist and NOACs, we found the non-Asian population were more on anticoagulants, whereas Asian population was less in oral anticoagulant, they were more on antiplatelet drugs. Coming to one-year outcome in patients with or without CKD, what we found that patients, those who are on CKD, both in Asia and non-Asian countries, they were having increased stroke and systemic embolization, major bleeding, all-cause mortality, cardiovascular mortality, non-cardiovascular mortality, new acute coronary syndrome, and heart failure, which was expected. When we compared the non-Asian patient with CKD with Asian patient with CKD, we can find all these endpoints, including embolization and bleeding, was much higher in non-Asian CKD patient compared to Asian CKD patients. Looking at the one-year all-cause mortality, for all the subgroups of patients with comorbidities like ACS, heart failure, CKD, and diabetes, what we found when we compared with the non-Asian population with the Asian population, all four of them have shown increased all-cause mortality. Looking at one-year risk of stroke and systemic embolism, for all the subgroups, similar findings were found that non-Asian populations, they have increased risk of stroke and systemic embolization compared to Asian population with the subgroup, with the comorbidities. 1 year major bleeding rates were almost similar to what we found in the other two findings in mortality and embolization. The major bleeding were again similarly higher in non-Asian population compared to that of Asian population in terms of that. So in conclusion, ladies and gentlemen, I would like to say the comorbidities, all four of them which we discussed with my other colleague, the diabetes, CKD, heart failure, and acute coronary syndromes are significantly observed in GARFIELD registry of more than 52,000 patients. In subgroup analysis of GARFIELD-AF registry, where we compared the Asian population of almost 1/4 of them versus the non-Asian population with comorbidities, what we found, the interesting finding, the non-Asian populations are elderly. They are on average 4 years more elder than the Asian population. They have more associated risk factors like hypertension and hypercholesterolemia, in certain comorbid conditions, even vascular diseases. They are more often treated with anticoagulants. They have increased incidence of stroke and bleeding. At the same time, they also have increased incidence of mortality. Thank you very much for your kind attention.
Now, ladies and gentlemen, you have already have a good picture of the Asian patient with newly diagnosed of atrial fibrillation as compared to non-Asian patient from the risk factor profile, drug usage, and outcome. Now we move on to the intra-regional differences in one-year outcome. First speaker is Professor Said O. He will talk about difference in the one-year event rate between countries in Asia. Professor O, please.
Thank you, Chairman. I will talk about the differences in event rates by region and country. Following is objectives to describe unadjusted event rate and cause of death over the first year after the diagnosis of AF, and second, to compare outcomes in patients of Asia versus non-Asia, and to describe differences in unadjusted event rate by region and by country. Based on the GARFIELD-AF registry data, we could analyze morbidity and mortality, such as cardiovascular and non-cardiovascular death, stroke, systemic embolization, major bleeding, acute coronary syndromes, and heart failure. This plot shows a distribution of cardiovascular scores of AF patients enrolled in GARFIELD-AF registry, cohort 1 through cohort 5, almost more than 50,000 patients. Dark blue color indicates Asia, almost 14,000 patients, and light blue indicates non-Asia, more than 38,000. As you can see, the distribution curve seems to be, the cardiovascular score distribution seems to be lower in Asian patients than non-Asian patients, although the mean value of the cardiovascular score seems to be similar. This table shows one-year event rates in Asia versus non-Asia. Numbers indicate event rates per 100 person years. In both Asia and non-Asia, the most common event was all-cause mortality. And in Asian patients, especially cardiovascular death, non-cardiovascular death, major bleeding, acute coronary syndrome, and congestive heart failure seemed to be significantly lower than non-Asia, although these are unadjusted data. But the systemic embolization stroke rate seems to be similar between Asia versus non-Asia. This table shows the proportion of cause of death, and in both Asia and non-Asia, most common cause of death was heart failure. And in Asian patients, proportion of ischemic stroke and malignancy was relatively lower than non-Asia. This plot shows one-year event rate by region. As I mentioned in the previous slides, Asian patients had lower major bleeding than non-Asia and lower mortality than non-Asia, but the stroke rate seems to be similar. Now, next, I'd like to hear from Dr. John Kim about the national differences in event rate and comments. Dr. Kim, please.
Mr. Chairman, ladies and gentlemen, good afternoon. I'm going to now talk about some differences between event rates in Asian countries. First of all, I'd like to remind you that there are considerable demographic differences between these 6 countries in Asia. And secondly, as we've seen, the treatment patterns are also very different. And therefore, perhaps we'll expect some differences in outcome. Let me also remind you that the population sizes in these different countries are quite different. For example, as you would expect, the size of the population in Singapore is nothing like as large as it is in some countries. The largest recruiter in Garfield was Japan, with almost 5,000 patients, and there were some 3,200 patients from Korea. Thailand had 1,500 patients, China 2,500, and India almost 1,400 patients. This table is a little difficult to see, so I've tried to highlight in green those countries with the lowest rates, and in red those countries with the highest rates. First, looking at all-cause mortality, you can see there's a very large range from 0.97 to 8.44, the largest mortality in India, the lowest in Korea. If we look at cardiovascular mortality, we see that this mirrors the overall mortality, with the highest figures in India and the lowest figures in Thailand and Korea. Note that there were no cardiovascular deaths in the 305 patients in Singapore. Non-cardiovascular deaths were highest in Thailand and Singapore and lowest in Korea. If we look at stroke and systemic embolism, it ranged from 0.85 per 100 person years in India to 2.47 in Singapore. Major bleeding also ranged from 1.05, highest in Singapore, to 0.23 in China. Acute coronary syndromes were lowest in Thailand and highest in Singapore, and the same could be said of heart failure, lowest in Thailand and highest in Singapore. Now, all the data that we've so far looked at in these Asian countries has been unadjusted data. They're just the crude rates. So the slide that I'm now going to show you will show you adjusted rates. You'll see that the adjustment involved the classical risk factors for bleeding and for thromboembolism. The statistic that is used is called the empirical Bayes estimate, and the global mean value, 0.0, is indicated by the horizontal line. So the top portion of the slide is devoted to all-cause mortality, and here we can see that it is highest of all countries in India, and low values are seen in Korea and Japan. The remaining countries have more or less the same as the global mean score. If we look at stroke and systemic embolism, we can see that all the countries within the Asian cohort had global mean values for the stroke and systemic embolism rate. With regard to major bleeding, we can see that there were low major bleeding rates in Japan and China, and the remainder were on the global mean, with perhaps the highest values being seen in Thailand. Now, turning back to unadjusted data for a moment to look at the causes of death between these Asian countries, we can see that heart failure and sudden unwitnessed death tended to be the most common causes, with the exception of a low value for sudden unwitnessed death in Japan. We can see that ischemic stroke, as in non-Asian countries, accounted for very few of the deaths in the GARFIELD-AF registry. This is an increasingly recognized point that major bleeding and ischemic stroke do not contribute very much to the mortality figures in atrial fibrillation. If we turn to non-cardiovascular deaths, we can see that malignancy was a common cause in most countries, except perhaps India, and infection was the second most common cause, although it was not reported in Korea. Respiratory failure overall was another common cause of non-cardiovascular death. So I'd like to summarize the two talks by Professor O and myself. Overall, the thromboembolic risk profile of Asian patients is lower than in non-Asians. All forms of mortality over the first year, and remember these are just first-year figures, are less in Asians. Major bleeds and acute coronary syndrome rates are also less in Asians. Stroke rates, however, are similar in Asians and non-Asian patients. And amongst the CV deaths, those related to ischemic strokes are proportionately more frequent in non-Asians. Amongst the non-CV deaths, malignancy accounts for a greater percentage of non-Asian deaths than is seen in Asians. And from the second talk, we have to remember that the sample sizes for the data analysis are only large in Japan, Korea, and China. The crude rates are changed by the adjustment for underlying cardiovascular risk. All-cause mortality was high in India and low in Korea and Japan. Stroke and systemic embolism rates were similar to the global average in all Asian countries, but it was a bit higher in Korea and a bit lower in Thailand. Major bleeding rates were lowest in China and Japan and higher in Thailand. The most common causes of CV death were heart failure and sudden unwitnessed death, the exception being Japan for this unwitnessed death, whilst death related to stroke was relatively uncommon. A relatively common cause of non-cardiovascular death is malignancy, and a comprehensive analysis of all of these data must combine consideration of the underlying thromboembolic and bleeding risks, the anticoagulant treatments offered, and then the outcome events. Thank you very much. I should now introduce my co-chairman, Shinya Goto, who's going to start a discussion of the economic burden of atrial fibrillation, the direct costs attributable to atrial fibrillation. Shinya.
Thank you, Professor Kam. I'm very pleased to share this data. You know, atrial fibrillation is a very common disease. We are now spending huge amount of money for healthcare. So what percentage of money we are spending? It's hospital visit, clinic visit, hospital admission, drug cost. That is the topic I'm trying to talk today. To describe the socio-economic impact and the direct cost attribute to atrial fibrillation in Asia. We are, talk about the Chinese example and the Japanese example. This project is proceeded by our Chinese colleague, Professor Zhujian K. So this is the kind of model we are calculating the socio-economic burden of atrial fibrillation. We are taking care of the visit cost. We are taking care of the admission cost. We are taking care of the drug cost. How much percentage of money for atrial fibrillation we are spending for physician visit, admission, drug? That I will talk. So these kind of data should have strong impact for the future policy making. So the population of the patient we analyzed are shown here. Charles-Basque score is just like this. And this is a kind of numbers we pick up in a GARFIELD database. Outpatient visit is more than 6,000. Hospital admission is 248. Emergency room visit, 8. Other 2. Stroke unit visit, 1. Unknown admission is 2. This is what happened in Japan within 1 year. So this is the economic burden of atrial fibrillation. We are defining the unit cost. I guess there should be a discussion, but with the publicable available data, if the patient visit to family doctor or other practitioner, it costs about 13,000 yen. If you are coming from the other country, just take 20. 130 US dollar or 130 euro, that is one visit cost. So how much amount of money we spend if the patient are admitted to the hospital by stroke? It million yen. It means $10,000. I'm wrong? Well, we are not using the decimal. So if the patient become myocardial infarction, 2 million yen, so 2 times more. So those are the costs for the examination, like CT scan, MRI, ultrasound, etc., etc. If the patient require PCI, we have to spend 2 million yen. That is a very vast amount of money. So how about the drug treatment cost? Aspirin is cheap, just 6 yen. It's almost zero in US dollar or euro. VKA is 30 yen, that is also very cheap. NOACs, rivaroxaban, dabigatran, daily cost is approximately 500 yen, that is $5, 5 euro, something like that. Based upon our estimation, what is the economic burden of atrial fibrillation? We spend inpatient like 36,000 yen, outpatient 50,000 yen, drug 100,000 yen.